Okay, good afternoon, everyone. Benjamin Dome here at the American Hip Institute's Friday afternoon fellows meeting, welcoming Dr. Sanjeev Bhatia as our guest faculty with the American Hip Institute. Dr. Bhatia hails to us from Northwestern Medicine and Central DuPage Hospital, and we look forward to hearing his cases and pearls. Over to you, Dr. Bhatia.
Thank you so much. Thank you so much, Ben. It's really an honor to be with all of you today. And, when you guys invited me to give this talk, I kind of thought a little bit about, what can I possibly talk to you about that may be of interest. Your group has done a phenomenal job publishing and innovating tremendously in our field, and we have a lot of gratitude for that. The area that I wanted to talk about to try to impart some wisdom as best I can is what it's like to be a hip arthroscopist when you first come out of your fellowship. This fall, will actually be my 5th year in practice, and the first 5 years of practice really are some of the. It's the period I think where you kind of have the most growth. So these are a few things that I think have, I've kind of, the 5 pearls from my top 5 pearls from my first 5 years of practice, and hopefully this will be beneficial for you. So, during the talk, feel free to chime in with questions if you have. I want this to be interactive, and, we'll kind of talk a little bit about concepts, and we'll go over a few cases as well to keep things interesting. So, let's see here, get this to move. There we go. So no disclosures pertinent to this. So the roadmap today, really we're talking about our tips for starting a practice. And really I want to make this as practical as possible to dial into the specifics on what I think are the most important things as a hip arthroscopist is starting out. So Pearl 1. So the number one thing that makes a hip arthroscopy patient successful is really proper patient selection. So I think everyone will kind of tell you that this is really the area where we as a field are getting better at identifying who is a good surgical candidate and who likely has, is not best suited for this procedure. So just to give you a case example, this is a 59-year-old female who was referred to me a few weeks ago or a couple months ago as a second opinion for persistent pain 6 months after having a hip arthroscopy. And prior to coming to see me, she had her surgery 6 months prior. She was having quite a bit of pain in physical therapy. Her surgery was done in the community, and she had quite a severe limp. So these are the initial x-rays that I got for her in the office. And you can see that she's got some features of dysplasia. She does not have bone-on-bone arthritis or anything. She does have some mild degenerative changes here, but for the most part, it's intact. So I treated her conservatively. We gave her an injection, bring her back. We bring her back a couple months later, and all of a sudden, she now has a very severe advanced osteoarthritis picture, and that was seen both on her X-ray and on her MRI. And incidentally, she does have a capsular defect and some subchondral cysts. So the reason I bring this up is, we really, as we get further along, you really want to dial into the cases to the people that you can actually help. And a lot of patients in that age group oftentimes they have a biochemical degeneration of their hip that many times you don't quite pick up just on routine time zero radiographs. This is a recent paper that you guys put out, which I thought was very fascinating, basically looking at, I presume, Dr. Dome's series, his first 200 cases versus his last 200 cases. And kind of going on to that point is, as you get further along in practice, you get better at picking out which cases do better, and you exclude out more degenerative changes, and that's kind of what some of the things that you guys saw in this paper. So, in my practice, the number one study that I think is the most important is the Standing Ap Radiograph, and technically the book answer is you don't want to have anything less than 2 millimeters of joint space or any type of subchondral cyst. In my practice, it's actually 3 millimeters. And again, I think that's really what helps us be most consistent with our outcomes. And this is what's been borne out in the literature as well. So, so the standing AP radiograph really is the most important. Other features that we really want to avoid are things that could result in hip instability. So poor predictors of preoperative predictors of poor outcomes are, a broken Shenton's line, tonus angle greater than 15, things along those lines. So, Brian Kelly did a very nice job several years ago in helping us kind of conceptualize the hip in multiple layers. And the key understanding with this in our patient selection portion is, we really want to only operate on people who have intra-articular pain. So, so that's why it's important, if you don't do this already, is to really incorporate ultrasound-guided hip injections as a big part of your practice. A lot of times fellows ask me, how do you do an ultrasound-guided intra-articular injection? I know you guys all do this really well, but a lot of times fellows coming out of other sports fellowships, this is one of the deficiencies, I think, in a lot of our fellowship programs. And, in the hip, if you want to be a hip arthroscopist, I think this is probably the most valuable tool that you can have for your preoperative decision-making, as it gives you real-time diagnostics in terms of helping see if something's coming from the joint. It's easy to learn, and in many cases, you can give people instantaneous relief in the office. So just a study we presented recently at the Academy, looking at the cost profile of an ultrasound-guided intra-articular injection versus a hospital-based fluoroscopic guided injection, either in the OR or in the radiology suite. And as you can imagine, there's a tremendous order of magnitude difference in cost savings when it's done in the office. So some pearls for doing this ultrasound, doing an ultrasound hip injection. The keys are really getting comfortable with the anatomy and knowing where your neurovascular structures are. The whole idea behind an ultrasound-guided intra-articular injection is we really want to make sure that the tip of our needle penetrates this thick, fibrous, leathery capsule, because that'll determine whether the injection is actually effective. This is how I do it in my office. I set patients up. It's probably similar to the way you guys do it. Patients are set up supine. We cut a hole in the paper shorts. Nothing is underneath. Palpate the ASIS, and then the ultrasound probe can be oriented. First, it's oriented transversely to the hip joint. This helps us look for the sphericity of the femoral head, gives us a landmark to kind of orient. Then we basically profile the probe along the femoral head-neck junction, and that gives you a very nice trajectory to aim for, and really aiming for the head-neck junction. So other things you can do with this tool, you can often do an iliopsoas injection. Many times this is a problematic area in some patients, either preoperatively or postoperatively, following a hip arthroscopy. And again, it gives us a very nice visual on what we're trying to inject. So just kind of move forward. So the second pearl that I've learned as a hip arthroscopist is really proper osseous management is key. And this is really, I would say, a big part of the learning curve. And I'm sure Dr. Dome and Dr. Lal would agree with this. A big part of the learning curve really is aimed at, is really because of, it's really an art form to get the right type of bone resection performed. So the biggest cause of revision hip arthroscopy in most situations is inadequate bony decompression, either on the acetabular side or on the femoral side. And my mentor and Ben's mentor, Dr. Philippon, really would have these pearls of wisdom when he was that he would impart to us. So number one pearl that met with surgery is good exposure is paramount. The second pearl or dictum is we need to respect the capsule at all times so you can close or plicate it later. We only want to remove the bone that is causing the pathology. Excessive resection can lead to an iatrogenic dysplasia or hip instability picture. And then Dr. Philippon, Mark Philippon would often say his key line would often be blue slopes, not black slopes. So that specifically means that we don't really want to have sharp edges or corners to our resection. So starting with the pincer side, our acetabular, our general treatment algorithm is when we get into the hip, number one is we want to expose the acetabular rim while protecting the capsule. So generally speaking, we're exposing the 12 to 3 o'clock area. This is usually when we're going to see any os acetabuli. This is where we will do our acetabular rim trimming and our subspine decompression. Then we'll turn it on to our labrum. So, the key move for the exposure for proper bony resection is being able to, number one, protect the overlying capsule, and then getting what's called this, we would call this the Philippon view, because Mark Philippon would always twist his hand and rotate his scope simultaneously. You guys have a very nice paper recently out where you quantified this as the upper deck view, and I think that this specific view is crucial towards being able to do a proper acetabular rim trimming, because only if you visualize the pathology can you actually treat it. And so those are the fellows who haven't really done this. Be sure to practice this in the lab, because this will really allow your skills to really leapfrog as a hip arthroscopist. So here is kind of what the bony work looks like with and without the upper deck view. So again, we're rotating our camera. It allows us to see above the acetabular rim. And when you get above the acetabular rim, you can get right on the junction of where the labrum meets the acetabular rim, and it allows you to get right to the exact pathology. So this is also how we'll address our subspine. A word about os acetabuli. Oftentimes we get questions on when do you fix it, when do you resect it. In general, you want to measure your preoperative lateral centroid angle and anterior centroid angle with and without the os. If the lateral centroid angle ends up being less than 25 degrees or less than 20 on the anterior centroid angle with resection, in that setting is when you would want to fix it with a cannulated screw over a K-wire. The subspine, I think, is an area where we've recently gotten a very good understanding of how it works and the pathology and the pathomechanics on this. So, as far as subspine impingement goes, it's technically the direct impingement of the inferior neck of the femur against the anterior inferior iliac spine with straight hip flexion. And just to kind of show you what this looks like, so this is a patient that we visualized with a virtual fluoroscopic dynamic software. And you can see that, whenever you have this large type 3 subspine, with hip flexion, your flexion is limited to this patient's flexion is only limited to 103 degrees. With subspine resection, that flexion is tremendously improved, where you get an extra 21 degrees of motion. So, again, the impingement process with the subspine is getting better understood, and our ability to treat it as also our awareness for it has gotten better as well. And I think as we've gotten better at decompressing the subspine, this also has made a big difference in our outcomes.
Sanjeev, if I could just interject, is that a software that you use routinely?
No, so this is actually not my software. This is a colleague of mine. This is a case of his, and so I don't use this routinely. Got it.
Yeah, I know there have been some that became available and then became unavailable and stuff like that in the past.
Absolutely. So type 2 and type 3 subspines, these are really the ones that we're aiming to do surgical management on. These are the ones that in general are symptomatic. So, indications for surgery with subspine impingement, really the key is pain with terminal hip flexion, tenderness over the AIIS, a type 2 or type 3 subspine on imaging, or, intraoperatively, if you see a lot of erythema and inflammation there, that's also an indication. I have a pretty low threshold to do a subspine decompression on most people, as I've found that it's a pretty effective tool at improving your outcomes. So again, these are kind of some other images. So I want to spend a good amount of time on the CAM pathology, because this is probably the most important area of the of the surgery that we do, because a lot of patients with large cam lesions, they're the ones who are most at risk of early chondral delamination. And this is probably the most important thing that we're doing. So our femoral osteoplasty steps, we obviously want to know where our vessels are at all times. Look for those at the beginning. I like to start distally, just like how Dr. Dome does. And that allows us to really get a sense of where our cam lesion starts, and it also allows you to focus on the sphericity of the femoral head. The key is really kind of switching to different viewpoints. We don't want any sharp gashes. And as Mark Philippon would say, we're trying to remove one cell at a time and create blue slopes and not black slopes. So just to kind of show you some of the steps, I use an interoral capsulotomy. Again, we're starting distally on the cam, trying to get a sense of where it starts. We're also trying to get a sense of the normal tissue, which is the normal femoral neck. And then we can basically work our way proximally from there to try to maintain a sphericity. So one of my good friends and former mentor, Shane No, he likes to do a Tee Capsulotomy. And the concepts really are similar. It's just that you're making a larger capsular defect that requires application or closure later on. So Mark Philippon's done some very good work on helping identify whether or not you've resected enough bone. And the key really, a really cool test to do is a dynamic impingement test, which most of us do. And it's really using an intraoperative assessment for guiding your resection and knowing where your impingement zones may be. The most common area of resection recurrent bone after a resection, I think that I've seen really has been the posterior lateral aspect of the femoral head neck junction. And most people don't get posterior enough. So that's really the trouble area that you want to focus on. So again, optimal osseous management really is the key to the survivorship of the procedure that we do. It's also it's the part that I think makes our surgery the most fun. It's a right brain maneuver as opposed to a left brain maneuver. It allows your sculpting your sculpting skills to really mature. So the key is we really want to get the perfect amount of bone without under resection or over resection. So again, osseous management, take your time, do it right. You really are aiming for the optimal recession with no sharp corners. Another pearl that I wanted to focus on is labral management. So this has really evolved a lot in the last, I would say, 4 to 5 years. There's been a lot of nice innovation that's occurred. So, when I was a fellow, Mark Philippon would often talk a lot about the suction seal of the hip. And, that was one of the first things we heard him say as a fellow. And I really never even believed it until I dissected this hip with one of my colleagues. And, essentially you can see up for yourself, how powerful that suction seal really is. And when you do a labor reconstruction, you can restore that at time 0 in a manner that would never exist otherwise. So it's really a cool visual to kind of appreciate that. One of the limitations with labor reconstruction is you do not get the normal proprioceptive nerve endings that inherently exist on the articular side of the human labrum. So in this study, all the nerve endings really are focused on the articular side, and they're aimed at helping with proprioception and other functions. So our labral treatment algorithm, number one is you always want to concomitantly address the FAI pathology. That's really the main cause of most labral tears. Labral repair is done typically in my practice anywhere between 3 and 5 anchors. Generally speaking, I try to preserve the labrum at all costs if we can. Sometimes we do an augmentation. Sometimes if it's a diminutive labrum. And labor reconstruction I'll do mainly for revision cases. In some cases, if it's an ossified labrum, and there's various techniques to do that. So, some of my colleagues, are big proponents of doing primary labor reconstruction in a lot of people, especially young people. Some would even argue that it's better than doing a labor repair. That's one of the arguments that's raging in our field right now. You know, my bias, and I think Ben's bias is also the same way, is, you know, there's no such thing as the tissue that you were born with. And there's a lot of reasons to really preserve your own labrum. A big part of that has to do with, you know, as when we put a cadaveric tissue there, rarely does it ever behave exactly the same way as a normal human labrum. So this is a case in point. This is a very nice study, which actually wound up being the most expensive fellow project that ever came out of Vail. Jeff Nepple did this a few years ahead of me, and this won an award at ISHA. This is a cadaveric distractive stability study that was done looking at the function of the labrum from a biomechanics standpoint. And you can see that, you know, basing the stability of the hip in the intact state, you know, when they did a normalized distractive stability test, you know, a labral repair restored that distractive stability by 80, or it was 84% of that. The labor reconstruction really only got to 66% of the normal distractive stability at time 0. So even at time 0, where you haven't had any settling in of your labor reconstruction, anything like that, your distractive stability with your suction seal still is not optimal. This was a recent letter to the editor that we wrote. Again, the debate on primary labor reconstruction rages in our field, and I'd love to potentially have a discussion with this afterwards. So labor reconstruction, we all know that it works very well in revision situations or in situations where your labrum is basically not salvageable. You know, recent paper a few years ago by Brian White, you know, labor re-repair group had 2.6 times more likelihood of failing than the labor reconstruction group. And again, the key is, you know, whenever you see a labrum like the one in the bottom corner, that's never going to be a salvageable labrum. There's just too much erythema, degenerative, diminutive tissue there that necessitates a labor reconstruction. So, you know, labral augmentation is a new kid on the block, and and I think this is going to take wave pretty significantly in the next several years. And again, the key is that it's basically a hybrid approach to to combining our skills with labor reconstruction with labor repair. So pearls for labor reconstruction, you know, the key, I think the key pearls for it are, the number one pearl I tell our fellows are the quality of the reconstruction really is related to the quality of the graft that you make. You know, always make your own grafts. If you're doing a segmental reconstruction, the length of the graft should precisely fit the need, and I'll show you a technique that we have for that. Placing all your anchors first and placing them as close to the articular surface really is the best for optimizing your seal. There's various suture shuttling techniques that you can do, and then suture management is a key. So this is a recent technique that we have on segmental labor reconstruction. And, you know, within labor reconstruction, there's a debate on whether you do an around the world reconstruction or a segmental reconstruction. This is the technique for the segmental reconstruction. And really the concept is that you're basically using, you know, you're using your you're using two anchors to really shuttle your suture, shuttle your graft within the joint. And this helps kind of stabilize the position of it. So I won't go into the specifics on this, but the concepts really are: first, you prep your acetabular site, place all your anchors in. Key is really getting your anchors as close to the articular margin as possible. That's what's going to give you a better seal. Next, you know, the key is measuring your labral defect, and you can use the suture of the anchors that you place. You can either measure the stripes on the suture graft, or this is a more reproducible technique where you actually make a knot in one of the sutures and you shuttle it in, and with the grasper you can actually get the precise distance with which your defect is. So this is our go-to technique now, where we basically place a mulberry knot on one end and then use a grasper to identify the exact distance of where of what that length is. So that's a pretty precise fit. And typically, I'll add 3 millimeters on the anterior side of the measurement and 4 millimeters on the posterior side of the measurement, and that gives us a pretty precise fit every time. So last step is really, one of the last steps is really bringing the graft in. This is where we're using our anchors to shuttle the graft in place. And typically the graft is brought in through the Dalla portal. That allows us to more effectively avoid the sutures that are, the mid-body sutures that are already in place. And then actually, before we do that, we're making our graft. So to make the graft, we're really, I like to use IT band allograft. One of the reasons I like this graft is that it's got collagen crosshatches that kind of are going in a perpendicular direction. As opposed to a tendinous allograft with some other tendons where it's easier for some of the sutures to rip out. And basically, we're trying to fold this in a manner that creates that tubular native structure of the IT band of the normal labrum. So this is kind of the fun step where you're actually bringing the graft into the joint. Again, we're gently shuttling both sutures on the posterior and anterior aspect, and that's what will help guide our graft into the right position. So we're using the sutures to really guide it exactly where we want to go. And one little trick for this is you can mark the sutures that you're going to grab to tie your post, and that allows you to more effectively and efficiently tie things very well. Last step really is we're just basically tying all our knots, fixing the ends. Next, we're going to tie past the mid-body sutures around the graft and then tie those knots. And then when we're all said and done, we really want to check our seal. And really what we're trying to reproduce is we're trying to reproduce a nice tubular graft with a good suction seal. And again, if you have a good graft, this procedure works very, very well. So, so again, the advantages of doing this kite technique segmental reconstruction, you can get a precise fit at our acetabular defect. It can be used for segmental or circumferential reconstructions. It's easier to control the graft. And again, there's a variety of techniques that can be done. You guys have a very nice technique using a posterior lateral portal, and that's an alternative way of doing it, which also works very, very nicely. So, so again, the key thing I want to impart is that, as a fellow, you learn a lot about labor reconstruction, and it's probably one of the coolest procedures that we do as a hip arthroscopist. But, one of the key things to take away is that, the labor reconstruction, it's a good surgery, but at the end of the day, it's always a salvage surgery. It's never going to be the same as a normal labrum that a patient is born with. So if we're able to preserve the labrum, either with a labral repair or a labral augmentation using a variety of techniques, that always tends to have a better success rate. So the other pearl that I have is that one of the things that I think has really become better understood in the last couple of years is really the function of the zona orbicularis. And we all really want to avoid a patient like this who basically has tremendous microinstability. This is a 33-year-old female, high-level former gymnast who came and saw me. She previously had a hip arthroscopy. She had some dysplasia, and she had quite a bit of capsular instability, as you can see with a simple distractive test like that. So microinstability is something where we as hip arthroscopists really have been driving the innovation in this, in our understanding in this. And Mark Safran deserves a lot of credit for some of the work that he's done. And basically the concept is when you have instability, that leads to soft tissue laxity, which then leads to pain, which then leads to disuse, which then leads to muscle weakness, which then basically repeats the whole cycle. So, I really want to give a big shout out to all of you guys and Dr. Dome's team for a lot of their work that they've done on capsular plication. this is one of the best papers I think that are out there in terms of describing the technique as well as the importance of helping restore the screw home mechanism of the normal capsule. And, and the paper that was outlined, has a very nice algorithm in terms of who benefits most from a capsular plication, who benefits more from a simple capsular repair, and who, in some cases, may benefit from a capsulotomy or in some cases even a capsulectomy. My good friend Damien Griffin recently had this very incredible anatomic video really depicting and illustrating the function of the zona orbicularis. So here's a view of the hip capsule looking through the acetabulum, and you can see that with the hip in extension, there's this wonderful screw home mechanism that's there. And then as the hip flexes, that capsule really relaxes, and that's really that's really the screw home mechanism in action, where many times I think this is very underappreciated by anatomists. So, the zona orbicularis, again, it's that thickening within the capsule that we really want to preserve. And, what's interesting about hip arthroscopy is this interportal versus Tee capsulotomy is really analogous to the rap battles of the 1990s, East Coast versus West Coast. So on one hand, you got your Tee capsulotomy guys who claim this is really it's my way or the highway. And on the other hand, you got interportal capsulotomy people who really believe in the zona orbicularis dysfunction. So, this is a debate that will always rage. It depends a lot on where you were trained and where your mentors were trained. My assumption is, I think you guys, correct me if I'm wrong, Ben, you guys are interportal people, right?
Yeah, you're right.
So, I think we're all kind of in agreement here. But, the benefits of the interportal capsulotomy is that it does not violate the zona. There's less morbidity if the repair doesn't heal. You can still access hard-to-reach places on the cam and distal femoral neck. Technically, it is a little bit faster because less sutures are needed for your capsular closure or plication. The disadvantages are it's harder to visualize. It does require more advanced camera manipulation, specifically maneuvers similar to the upper deck view that we were talking about earlier. And it may not plicate as well in some cases as a plication, particularly distally down your femoral neck. And it does, and some would argue it does require a little bit more of a posterior extension than a Tee capsulotomy. The Tee capsulotomy, some would argue it can be done without violating the zona orbicularis. It does give you the best visualization down the distal femoral neck. Theoretically, you're doing a more pants over the vest plication over the distal aspect of the femoral neck. The disadvantages of Tee capsulotomy is it requires more capsular plication, at least 4 to 6. You can violate your zona if it's done too distally. And there's a concern for instability, especially if the repair doesn't hold or it doesn't heal. So, my biggest argument against the Tee capsulotomy is using the number one proponent of Tee capsulotomy that I know, Shay No, using his own research against him. So this was a paper that he put out several years ago, really looking at the effect of the capsulotomy and capsular repair on hip stability. This was a biomechanical study in which they took 7 frozen cadaveric specimens. Long story short, they basically made various capsulotomy types, and they placed this in a hip model to assess for stability. So they looked at the intact state, the interportal capsulotomy state, so the 4-centimeter capsulotomy, a Tee capsulotomy, a repaired Tee capsulotomy, and then a capsulectomy. So here again is the Tee capsulotomy state. This is the repaired state. This is the capsulectomy state, and so forth. So the key findings on this are that as you can imagine, the intact state had the most optimal stability. But the second most optimal stability was both in the repair group as well as in the unrepaired interportal capsulotomy group. So to say that another way, the unrepaired interportal capsulotomy had essentially the same stability as your repair group, whereas your Tee capsulotomy group had a significantly higher instability findings. So the findings of this basically state that, let's say you do a Tee Capsulotomy and you have sutures that either pull out or something doesn't heal. You're essentially stuck you've essentially created iatrogenic instability in the hip. Whereas with an interportal capsulotomy, if you don't get your plication or your repair to heal, you're still left in a reasonable state. And that's because you've not violated the zona orbicularis. So, some people have taken this a step further, and Omer Maidan's group has argued that an interportal capsulotomy that's 3 centimeters long does not need to be repaired. So, this study was a double-blind randomized controlled trial where they used postoperative MRI imaging. They noted that all capsules healed at 24 weeks without any difference. So, again, my argument for closing the interportal is that, at times that you can get, and that's seen on various anatomic time zero studies. And here's one example is, just 3 simple sutures in the interportal provides a significant amount of stability to the hip joint, which I think is beneficial. So one of the areas where I think is most poorly understood, and I think this is something that I've learned quite a bit in my first few years of practice, is really the importance of the rectus femoris to the relationship of the rectus femoris to the capsule is a very important one that I think needs to be respected at all times. So, the rectus femoris really has 2 heads, the direct head and the indirect head. And both of these tendons are very intimately tied with the location of the capsule. So a common error is that this rectus often gets tethered to your capsular repair, which I think is a notable source of pain. So during your procedure, you always want to protect the capsule, as we discussed, especially as you're exposing the acetabular rim. You don't want to eat away your capsule proximally, as this could often cause issues. But this is a step that I think is, for many hip arthroscopists who are starting out, I think this is a step that is very underappreciated. And basically, that it's when you're about to do your capsular closure, you essentially want to separate the rectus from the proximal leaflet, because inadvertently many of your stitches may accidentally tether a portion of that tendon into your capsular repair, and that can be a big source of postoperative pain and instability. In fact, Tom Bird would argue this may be one of the dominant causes of hip revision. So, capsular repair or capsular plication, there's a variety of techniques to do it. Really, I think the key concept is, whichever suture technique you use, tie your stitches with the hip in extension. And that really is to help make sure that you don't tie anything too tight. That also will help make sure that your patient can accurately get, full hip extension postoperatively, which will make it easier for them to progress from phase 1 to phase 2 in the rehab. So, that brings us to our last pearl, and that's really focusing on the rehabilitation aspects of it. So, one thing that, which is a big research interest of mine, and that's really assessing how the dynamic pelvic tilt changes both preoperatively as well as postoperatively. And I think this is an area that, as a field, we're really going to focus a lot of time and energy on understanding better in the future. So just to kind of give you an idea, what is dynamic pelvic tilt? So, we all know that early passive range of motion hip arthroscopy rehab is critical for a lot of, having appropriate postoperative function after hip arthroscopy surgery. But when I'm talking about dynamic pelvic tilt, I'm talking about the motion with which the pelvis moves with regards to the lumbar spine and with regards to the femur with activity. So this is a 21-year-old college soccer player of mine, where after her surgery, where she was rehabbing at her university, they had her on a gait lab. They were fortunate enough to have a gait analysis lab, where they can analyze her pelvic tilt and some of these other parameters. And you can see here on both of these videos, she's running at the same speed. But on the video on the left, this is 3 months after hip arthroscopy. This is where a lot of her muscular endurance and dynamic control has not yet fully normalized. So think of this patient on the left as being in a posterior pelvic chain deficient state, which we would expect roughly around the 3-month stage after hip arthroscopy. And you can see that that pelvis is bobbing forward anteriorly. So as it does that, it makes it easier for impingement pathology to be more symptomatic or have more symptoms on the front part of the hip. It also kind of, it's just a more economically, there's less economy of motion, which creates more, more symptoms. So whereas on the right, you can see that with good trunk and posterior pelvic chain control, there's noticeable improvement, not just in the pelvic tilt, but also in the control with every stride. So this is kind of what we're trying to do in our postoperative period. So the 4 phases of PT really are protection. That's the first 4 weeks. We're just trying to get things to calm down. Initial strengthening is weeks 4 through 10. We're trying to really get a non-compensatory gait with progression. Advanced strengthening in my practice starts around weeks 8 or 10. And then usually we're trying to aim for full return to sports anywhere between 4 and 7 months. So safe and successful return to play is really our goal. So the nice thing with hip arthroscopy is, and Ben can attest to this, in the last 10 years, there's really been a tremendous evolution in our outcomes and our success rates with a lot of hip arthroscopy. Much of this is owed to our patient selection as well as the evolution of some of our techniques. And really, the procedure is very durable at 5 to 10 years with modern techniques, including in high-level athletes, as we've previously talked about. So, just to summarize, the pearls, patient selection is paramount. Osseous management is key. That's really a big part of our learning curve. Labor repair and augmentation is critical. When we can do it, labor reconstruction in settings of poor labrum and poor seal. The zona orbicularis is there for a reason. Try to preserve it. Dynamic pelvic tilt is an area where I think we'll start to hear more about in the future. So I want to close with a few cases that I have. So case 1, and we'll kind of zoom through this a little bit. We'll kind of open things up for questions. So so this is a 22-year-old male, high-level Division I collegiate basketball player, 13 months of sharp hip pain, wants to play basketball professionally. He actually had some opportunities out in Europe. He had to sit out his last 2 months of his senior season. This was back when I was in Ohio. And so, he presented to me in typical fashion. So, again, this is a healthy, active guy, heavy thigh musculature, all the classic signs that we typically see. These were his preoperative hip scores, and to the fellows, I would encourage you that when you go out and practice, one of the things that you guys probably have seen done very well, at the American Hip Institute, you guys get preoperative hip scores, postoperative hip scores. In addition to being able to track your outcomes and be useful from a research standpoint, this is a very, very useful tool also in your patient decision-making. So, again, we're trying to, in every patient that we're operating on, we're trying to help them achieve the minimal clinically important difference in their score. And so if they have a very, very high score on their modified Harris hip or some other PRO, that means odds are they're not going to be that happy post-op because there's not a big area of improvement. So these are some of his preoperative images. The key finding is that there's a notable focal cam lesion, and he essentially has cam dominant FAI. Has a labral tear on MRI. This is what we saw in his case, and basically had a frayed labrum that was repaired. We did a standard procedure, asked to have a rim trimming, labor repair, really took down that large focal cam lesion. And this is one of my first few cases in practice. And this was basically the surgery that made me excited about being a hip arthroscopist. This gentleman had a very good outcome, went back to playing in Europe, had a very durable result. I actually have several years out as well, and he's currently still playing in Europe with no hip pain. So, I presented that case first for a reason, because you can't always look good. So I also wanted to present some more humbling cases. So this is a second case. This is a 31-year-old with persistent pain 2 years after hip arthroscopy that I did. So this is a 31-year-old male PACU nurse from my hospital back in Ohio. Persistent tenderness over the anterior hip flexor 2 years after a hip arthroscopy. His index hip arthroscopy, had a labor repair, femoral osteoplasty, capsule repair. His post-op rehab was notable for having, for him stopping PT for personal reasons at the 4-week mark and resuming it at 10 weeks. Some of this was insurance related. He had a slow recovery due to persistent hip flexor tendinitis, which I think all of us have seen at some point in our practices. And he returned to sports, but he always kind of had this, this irritating tenderness over the rectus femoris iliopsoas area post-op. So we did quite a bit of rehab. We treated him with dry needling, Iliopsoas injections, temporary improvement with all that stuff. This was his exam 2 years post-op, some pain. Really the key thing is pain with a hip extension and external rotation over about the hip flexor. He had no instability signs. He had good strength. So these are some images from his first hip scope, labor repair, femoral osteoplasty, capsular repair. Here was his, these were some of his scores, preoperative hip scores. So this is, so again, this is his, these are some of his X-ray images here. So again, no major heterotopic ossifications or major cam regrowth. Some areas where it looks like there's been a little bit of regrowth on the femoral side. Here was his MRI, no new capsular defect or anything. Some post-op changes, no discrete labral tear. So, I took him back for surgery, and we were a little bit, part of this was diagnostic, but the arthroscopy is very, very revealing. So, he essentially had severe scarring at the capsule rectus area, which was lice. And then in addition, his labrum was so scarred that I decided to do a labor reconstruction using our technique. And again, one of the things that we had a good labor reconstruction that was done. One of the key things that we did see is that he had so much scarring between the capsule and the rectus. I essentially re-repaired the capsule after a bigger separation of that scar. And, since this case, it's really changed how much I elevate the rectus after whenever doing this procedure. I think that's a big part of, reducing the likelihood of having that excessive scar in that area. So fortunately, post-op, after his revision surgery, he did very well, and he's still doing well right now. Here's another case. We'll just kind of, I know we're running a little bit out of time.
Sanjeev, I have a question. I was wondering, I haven't seen any previously about release of the indirect head of the rectus femoris, even in the primary setting, because we do it often in total hips, or people use it for reconstruction of the labrum. So, and I don't know if anybody's really looked at what the role of the indirect head is in the fourth generation of the quad. So I wonder if there's a role for, even release of the rectus, the indirect head, even in the primary setting. Maybe that's what's causing a lot of anterior groin pain and, snapping maybe.
Yeah, no, and that's an interesting thought. Yeah, so, from a release standpoint, what I do is I don't technically release the direct head. So the main head that we're talking about in these images is a direct head anteriorly, and what I do is I elevate the direct head off of the proximal leaflet. And so there, the nice thing about that tendon is if you look at the anatomy, it has a very broad insertion. So you can easily elevate, the bottom, almost 50% of that, and there's quite a bit of an attachment that that really never cause any problems. The other nice thing about the rectus is it has two heads. So, you're really never going to have a true instability issue while doing that. So, but no, I think you're exactly right. I think the rectus is something that, I think this is an area that hopefully needs a lot more research. There, perhaps it's analogous to the long head of the biceps in the shoulder, similar to rotator cuff repair. That's a good thought.
So were you suggesting that release of the indirect head?
No, the direct head.
The direct head.
So when I say release, I'm not meaning like release off the bone. I just mean elevation off the capsule.
Right. Okay, got it.
Just
And what do you do? What's your view on the indirect head as it sort of lays on top of the capsule as you get out more laterally? It becomes almost confluent with the capsule out toward 12 o'clock. What's your view of that part of that?
Yeah, so my clinical experience has been that if we plicate too laterally, sometimes and I'm theorizing that sometimes I've noticed that if I plicate too laterally, those patients are a little bit stiffer, particularly with external rotation, when they come back to the office. And my theory is that if you plicate too laterally, you may indirectly capture some elements of the indirect head, where that may cause a pain response or kind of a tightness response. So I think that
so I was actually talking about the indirect head, not the direct head.
Yeah. So
to release the indirect head, like you say, it can cause problems when you're closing the capsule, and maybe that's I think that the indirect head is more like the long head of the biceps. And
I think,
or the short head of the biceps.
Yeah, no, I think there's a lot of analogies, and maybe even an evolutionary analogy to that. Yeah, no, I mean, whether you're talking about the indirect head or the direct head, I think the concept is the same, that, if we tether it, it's going to absolutely cause pain post-op. And I think that's an area that is a big source, at least in my practice, I've seen as a big source of revision in a lot of cases that have come to me. Where the previous surgeon kind of, everybody now wants to close the capsule. It's become a very, important thing that's been discussed at a lot of meetings. But in some cases, I do think that we can close it too tight, and in part, it's if we accidentally get the rectus. So, but no, good thoughts. Yeah, so I'll just kind of breeze through some of these other ones. This is a synovial chondromatosis case. Some interesting findings inside. That's a cool thing about hip arthroscopy is, there's such a variety of cases and pathologies that we can treat. And, it blows my mind. And I can't imagine, Ben, what this was like when you started your practice, 10, 15 years ago. And, people probably thought you were crazy for sticking a scope in a hip. The amount of pathology that's in there that really never was accessed. This is a guy, 35 loose bodies from synovial chondromatosis. This guy would have basically just sucked it up for, 10, 15 years, until he got, advanced arthritis. And so, we can now treat that very successfully. Here's another case. This is an instability case. 30-year-old school teacher, left hip pain insidiously. She really presented with being on crutches due to pain. And to me, that's usually a sign that there might be a dysplastic etiology of issues going on. So, had a coxalgic break gait, on crutches, positive Fader sign, some joint laxity on exam. She didn't really have anterior apprehension or anything like that, but she did have some joint laxity. X-rays show borderline dysplasia versus hip dysplasia, depending on how you want to classify it. And because of her joint laxity, we decided to treat her. Also had a labral tear. So because of the joint laxity coupled with the dysplastic findings, decided to treat her in a combined fashion with one of my partners, Mike Stover. And really, she wound up having a staged hip arthroscopy PAO. We're now doing these together in the same setting, but basically had a PAO a week later. She's currently 3 months out from that procedure. Here's another case. This is an unusual case. This is a 21-year-old soccer player. Basically came in for a second opinion, had an injury 5 months prior to his visit, where he had a very sharp pain, pop anteriorly, had a ton of bruising pain and swelling. His training staff treated him with an intra-articular steroid injection that wasn't helpful. And really his pain was so severe he couldn't even sit. So, his exam was classic for really, severe subspine impingement, palpable tender mass in the AIIS, pain, sharp pain with hip flexion, straight flexion. And on X-ray, you can see this huge area of heterotopic ossification and or myositis ossificans. And so this is basically what his CT scan looked like. Again, a huge area of bone formation just lateral to the subspine region. So essentially what happened was his rectus femoris avulsed off, and this injury really only happens in high-level soccer players. And he had a small labral tear, basically the way that we treated this was, this was very large and it was very posterior, plus his rectus was off, and I wanted to make sure that his rectus gets back on. So treated him with a DA approach, open rectus femoris repair with 2 suture anchors. This is kind of what it looked like. That big chunk of bone was easy to plop off. And essentially, again, did that direct rectus femoris repair. As is the case in people who have very severe impingement, had a very nice outcome with this. This is what the rectus femoris repair looks like. Here was our rehab course, partial weight bearing for 6 weeks. We allowed him to ease back into soccer around 5 to 6 months. And again, had a very good result, as is often the case with people with severe bony pathology. So I know we're kind of running out of time. I have a few more cases. I can either go through them or we can kind of open it up to questions.
I don't think we have an endpoint necessarily, no hard endpoint, Sanjeev. So whichever you want to do.
Sure. Okay, I'll just kind of present a couple other cases. This is a greater trochanteric pain syndrome case. This was another real life case that university administrator, my last practice, 1 year of focal lateral sided hip pain, and really kind of failed everything. 4 months of PT, trochanteric bursal injections. Let me ask you guys something. How many, when you guys see greater trochanteric pain syndrome patients, what is your protocol for injections? How many injections do you do, and what kind of injections do you typically recommend?
Pick on a fellow.
I forgot the names already. Forgive me.
All right, I'll pick a name for you, Kobe. Kobe, we can't really hear you.
Hello, interrupted.
Okay, all right. I'm going to pick a different fellow, Kobe, till you get your sound together. How about Mitch?
For this, I think that Australian study, Fitzgerald or Fitzpatrick, demonstrated that PRP probably would be more beneficial than a steroid injection in these instances, I would believe, for longer-term benefit. So I'd probably, if it's feasible for the patient, I think PRP injections, if any injections, would be the most beneficial for this patient.
Got it.
And if you do a steroid injection, how many?
I mean, I know that there's that saying intra-articularly you want to space them out once every 4 months, but repetitive steroid injections in the peritrochanteric space with the tendon there, I would try to limit it as less as possible. Maybe one, possibly two, but no more than that.
Yeah, I don't think I've ever done more, or rarely done more than one.
And
Yeah.
Sanjeev, I would sort of add to that I forget who taught me this. Oh yeah, it was Dr. Dome. But if you put a steroid injection into someone's shoulder, in the muscle in the deltoid, it's going to make their hip feel better. It sort of gets a little bit systemic, and so we're dropping. You hear these people getting multiple rounds of cortisone injections in and around their gluteus medius or their peritrochanteric space, and it helped for 6 months, then it helped for 1 week, and then what you're really doing is not knowing where the medication's going. But I think the most pertinent thing on your history there is that your intra-articular injection was not helpful. That's pretty critical. I think in our clinic we have to rule out an intra-articular source of pain that's radiating to the peritrochanteric space. If that's negative, and you've got imaging and clinical findings that are concerning for GTPS, then you're going down the right sort of diagnostic algorithm here to treat the patient for what they need. If that if that intra-articular injection relieves their pain, they may be a candidate for other intra-articular work. So whether it be arthroscopic or arthroplasty in combination with their GTPS management. But I think that's critical. I'm glad you have that there, because you got to rule out the intra-articular source of pain that could be radiating to that space.
Another thing that we have on the history here is lumbar spine fusion. So sometimes this pain can also be radiated from the spine. So it could also not be GTPS unless there are other things that suggest that.
Great points, everyone. Yeah, no, that I couldn't agree with everything you said more. And that's basically the same thing with regards to the steroid injections. I feel exactly the same way, Ajay. Basically, if you do, in my practice, it's essentially, you get once, because if we can't do PRP, because a lot of times it's cost prohibitive, we essentially do one steroid injection, and if it's not effective at curing the problem, the first line treatment I do is PT. I have them do that for at least 6 to 8 weeks. If they still have pain, our next move will be to potentially consider a steroid injection versus PRP. And then I typically won't ever do more than one steroid injection for all those reasons. And you're right, the intra-articular injection, very helpful in terms of ruling things out. And whenever, we always got to be on the lookout for concomitant lumbar radiculopathy. And that's really critical. So, this gentleman, it really, I felt pretty confident that this was coming from the greater trochan, the GTPS, mainly because he had, very severe focal point tenderness over the trochanter. He did have some weakness with his abductor, and it really had no other, signs of radicular issues. This is an interesting thing that we saw in his imaging, and I'm curious how often you guys see this as well. This is a calcific enthesophyte in the gluteus medius, and just like calcific tendonitis in the shoulder, I do believe this is a notable source of pain that probably has been seeing us more than we've been seeing it over the last several years. So so this gentleman, took him to the OR. I did not go into the intra-articular space because of his preoperative intra-articular injection. And this is kind of the first view that we get when we go into surgery into the peritrochanteric space. And one thing that and I'm curious, Ben and Ajay, about your thoughts on this. I think there's a little bit of a debate on whether or not you do a concomitant IT band, an IT band release whenever you're doing a peritrochanteric procedure. My preference is to try to preserve the IT band, especially when we're doing abductor tendon work, because I think it has an important role. What's your guys' take on that?
Yeah, pretty similar, Sanjeev. I always, when I started doing these, I think the only other people who were doing it at all were windowing the IT band, making a big release, and they thought that was therapeutic. And then sometimes they were repairing the gluteus medius, but probably only if it was a full thickness tear. And I've viewed it almost 180 degrees opposite that from the beginning. My feeling was that the IT band is actually an abductor of the hip. And so if the gluteus medius is torn, the last thing I want to do is compromise the other abductor of the hip, and I want to preserve it. So we have always done these from within the IT band, never compromising the IT band, with the exception of when there is actual painful snapping. That I think is a different entity, but that's very rare in my practice.
Right. Same. I agree completely. And I think the the other reason that I think, I've seen a lot of people who have had the IT band release being too long, and in some cases the troch actually herniates through that area, and I think that's a source of pain or catching as well.
Absolutely.
So again, this is kind of what it looks like inside. Here was that calcific enthesophyte that was in the gluteus medius. So basically debrided that, took that down, concomitantly did a gluteus medius repair. So these are kind of kind of what it looked like. Here's our final repair construct. And, fortunately, he did very, very well. Immediately post-op, his pain was gone at his first post-op visit. Again, a testament to that. Similar to how calcific tendonitis patients in the shoulder behave, normal ambulation and strength. We treated him with no active abduction and touchdown weight bearing for 6 weeks. Here's an open case of a similar thing, lateral snapping over the trochanter. Similar woman, 69-year-old woman, no anterior pain, all lateral sided pain, had preoperative severe snapping. Had reasonable strength on her preoperative exam, a little bit of minor weakness with abduction, and really had a large ossific fragment on her trochanter. And, this is one where I decided to treat this open, mainly because of I wanted to make sure that we had a very good, I cleaned things out very well and got that big fragment out. So, essentially treated her open, open trochanteric bursectomy, excision of ossicle and large osteophytes, wound up doing a double row repair of her abductor tendon tear. Got a very nice repair, this was her rehab process. Her snapping symptoms resolved after surgery, full ambulation, good full strength, achieved by 4 months post-op. So, just to close, again, our pearls that I want to mention is, really the key to any arthroscopic hip surgery is, patient selection is paramount. I think it's more important in the work that we do than I think in any other procedure in sports medicine. I think it's really, the preoperative patient selection, I would argue, is potentially one of the biggest parts of the learning curve, along with osseous management. Labor repair and augmentation is becoming more in vogue. There's no such thing as the original labrum that you're born with, in my view. Labor reconstruction, however, is a very, very good procedure in people who have poor labrums or unsalvageable labrums with poor seal. The zona orbicularis is the most important structure in the capsule. And then I think dynamic pelvic tilt will be more optimally studied in the future. So with that, again, it's a team. The cool thing about hip, it's really a team approach, and really awesome to collaborate with you guys. And thank you again. Appreciate it.
That's great. Thank you very much, Sanjeev. If you have a few more minutes, maybe I could just let the fellows ask you some questions if they have any.
I'd be honored. Yeah, for sure.